from rest part of the world. Today, our guest speaker for the day is Professor Dr. Andrew Davis from Southampton, UK, and he's going to lecture us on new approaches to relapsed and refractory DLBCL. This webinar is brought to you by Mumbai Hematology Group, supported by Roche, Natco Oncology, Lucien Life Sciences, and Nirvin Life Sciences, and managed by Perfect Square. I thank Team Roche, Natco, Lucien, and Nirvin, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Professor Dr. Andrew Davis from Southampton, UK. All our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants who are spending your Sunday morning, afternoon, or evening from whichever part of the world you are logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 5th of October 2024, from 7 p.m. Indian Standard Time, we have Dr. Abhishek Sharma from NRS Medical College and Hospital, Kolkata, speaking to us on interpretation of peripheral blood smears. And the following day, that is Sunday, 6th of October 2002, from 11:30 a.m. IST, we have Dr. Devdutt Basu from Pondicherry, speaking to us on when your cells go missing, unraveling the mystery of pancytopenia. Let me introduce our discussants for the day, and we have galaxy of them here displayed in alphabetical order. To start with, we have Dr. A.K. Ganju from Nagpur, Dr. Akanksha Garg from Zydus Hospitals and Zydus Cancer Center, Ahmedabad, Dr. Akash Khandelwal from Action Cancer Hospital, New Delhi, Dr. Anil Sharma from Cancer Hospital and Research Institute, Gwalior, Dr. Anupama Jaggia from NHS Trust, London, Sergeant Commander Dr. Arun V.A. from INHS Aswini Kolaba, Mumbai, Colonel Dr. Ashok Meshram from Command Hospital, Kolkata, Dr. Avinash Kumar Singh from Paras HMRI Hospital and Patna Hematology Clinic, Patna, Bihar, Dr. Deepak Charles from Aston Medicity, Kochi, Dr. Fahima Hassan from United Institute of Medical Sciences, Prayagraj, Dr. Kavya Kirthana from AIIMS, Delhi, Dr. Nutan Joshi from Christian Medical College, Vellore, Dr. Prashanta Bhatt from KMC Hospital, Bengaluru, Dr. Radhika KK from Nizam's Institute of Medical Sciences, Hyderabad, Dr. Roshni Pandey from Mahakoshal Hospital, Jabalpur, Dr. Sandeep Partake from Bharati Vidyapit Medical College, Pune, Dr. Sanjukta Rao from St. John's Medical College Hospital, Bengaluru, Dr. Satish Kumar A from Manipal Hospital, Yashwantpur, Bengaluru, Dr. Siddesh Kalantri from Blood Care Hematology Clinic, Nashik, Dr. Sundar Shivale from TMC, Kolkata, Dr. Vishwadip Khushu from AIIMS, Nagpur, Dr. Yi Won Tan from North Okalapa General and Teaching Hospital, Yangon, Myanmar. Now is the time to introduce our guest speaker for the day. We have with us no other than Professor Dr. Andrew Davis from UK. Professor Dr. Andrew Davis has given multiple lectures in the past, and today again he is with us to deliver the lecture on DLBCL. It's my formal duty to introduce Professor Dr. Andrew Davis. Dr. Andrew Davis is Professor of Hematological Oncology in the Faculty of Medicine, University Hospital, Southampton, UK. He specializes in the treatment of malignant lymphoma. His work focuses on translation of biomarkers and novel therapies to the clinical arena. He has extensive experience in early phase trials along with the delivery of practice-changing late phase studies. He is chair of UK NCRI Lymphoma Research Group. He is also the director of the Southampton Experimental Cancer Medicine Center. He is also regional lead for cancers in teenagers and young adults. And today he is going to speak to us on new approaches to relapsed and refractory DLBCL. Well, thank you so much. I stop over here. Over to you, Professor Dr. Andrew Davis.
Well, good morning, everyone, and thank you for that very kind introduction. It's very great to be here again with you at the Mumbai Hematology Group. Thank you for inviting me once again. And the topic today is going to be talking about new approaches to relapsed and refractory diffuse large B-cell lymphoma. So I hope you can see my slides okay. And but my first tip says I've obviously got a number of conflicts of interest to declare. I have a lot of interactions with various pharmaceutical houses because they're doing early drug development. So you'll be aware there's multiple conflicts of interest. Now, so let's talk about diffuse large B-cell lymphoma, the commonest of the B-cell non-Hodgkin's lymphomas. Our expectation of success in diffuse large B-cell lymphoma is high, and we can see data from the last clinical trial that we did in the UK, 1,400 patients, and we saw that 80% of patients at least were alive 2 to 3 years after diagnosis. However, if we look at real-world population data, we can see that that figure is somewhere in the region of about 60%. And we recognise that patients who go into clinical trials are a special breed. They tend to be younger, they have a better performance status, and they tend to carry less comorbidities. So the real-world data tells us that actually a lot of patients are being failed by our current approaches to DLBCL, and we've got to do better. Now, we're quite good at telling which patients are going to do well and which patients are going to do less well. We use the IPI score now for some 30 years, really, that can divide the population up according to clinical risk variables. And so for the age, stage, performance status, lactate dehydrogenase, and the number of extranodal sites. And therefore, if you have few of these risk factors, then your expectation of success is high, and few patients will relapse. And we can see that overall survival approaches 95% in those without risk factors. But for those patients who have multiple IPI-defined risk factors, their overall survival is somewhere in the order of about 50%. So we can identify which patients we think are going to be clearly of higher risk of failure. And then we can layer on some information about the biology. And of course, we can think about the transcriptionally defined subcategories of diffuse large B-cell lymphoma, which simply divides DLBCL into two groups, the activated B-cell subtype and the germinal center B-cell subtype. And we recognize this is a simplification, but we recognize also that those with the ABC phenotype have a worse prognosis than those with the GCB phenotype. And of course, we can add information about oncogenic aberrations. And for those patients with DLBCL morphology that have translocations involving MYC and BCL2, then they're going to have a worse prognosis than those patients that either have just a single MYC translocation or those patients who don't have oncogenic aberrations. And we can also use the PET scan at baseline to help us predict which patients we think are likely to fail. Information about the metabolic tumor volume can add to the fidelity of the IPI score, and we've seen the development of the International Metabolic Prognostic Index by a large collaborative group looking at PET data. And essentially it adds the total metabolic tumor volume to the IPI score to bring us a greater prediction of outcome. And you can see that patient who is in panel A, who has a large total metabolic tumor volume, some 3.5 to 4 litres, is going to do much less well, unfortunately, than that patient in panel B, who's probably got a total metabolic tumor volume of just 300 mils. And so I think the PET scan is useful. Of course, it's useful as a marker for interim response to predict those patients who are going to do less well. And of course, at the end of treatment, the PET scan is also quite a sensitive tool in terms of predicting response. There are also new tools coming on the horizon, and there are thoughts about how we might use these in clinical practice. This is data from Mark Rosetsky, which looks at ctDNA taken at the end of induction therapy for DLBCL. And you can see over on the right-hand side, using a highly sensitive assay, those patients who were ctDNA negative in the dark blue, those patients did not relapse. The only event here on the progression-free survival was an unrelated death, not related to lymphoma. And in the red line, we can see those patients who still had MRD sensitivity defined by ctDNA that were positive. And we can see that those patients, unfortunately, had a much less good performance in terms of outcomes than those patients who were ctDNA negative. And if we look on the panel on the left-hand side, this is exactly the same cohort, but looking at the end of treatment PET CT scan to predict recurrence. And you can see the performance of the biomarker is inferior to the performance of ctDNA. And there's a lot of thought about how we might approach this group of patients who are ctDNA positive. It's probably about 20% of patients, and whether we should think about offering those patients at the end of induction therapy some sort of consolidative strategy. But I show you this data just to demonstrate that we're increasingly able, beyond the IPI, to predict which patients are going to do well and which patients are going to do less well. Now, for those patients who have R-CHOP chemotherapy, we recognise that, as I said, we probably cure about 60% of patients. And so that leaves this group of patients as about 40% or thereabouts who either relapse after achieving an initial complete remission with R-CHOP chemotherapy, or who have refractory disease from the outset. And the definition of refractory is very variable. You have to always be very careful about how you define that when you're talking about it. And we can see that with traditional immunochemotherapy used at relapse, unfortunately our outcomes have been very poor, and we see a median overall survival of patients somewhere in the order of about 6 months. And I think that's really obviously very disappointing, seeing that 20% of patients are alive 24 months after the time of relapse. So it's been really important that we have seen a big change in our therapeutic landscape in relapse and refractory diffuse large B-cell lymphoma. We understand, I'm afraid, little about the biology of relapsed refractory DLBCL. It's a very active area of research. We see in some patients the same pattern of mutations that are present at diagnosis, and then we acquire additional mutations that may confer resistance at the time of relapse. That variability in mutations stated in refractory disease patients is probably less so, and I think that the outcome for refractory patients tends to be more fixed at the time of diagnosis. But certainly this is an area where we need to do much more work to understand the biology. Now, there's plenty of new agents that are available in different territories now for the treatment of relapsed and refractory DLBCL. The landscape has completely turned on its head, and I think that we have to recognize when we think about our new algorithms for patients with relapsed and refractory DLBCL, we have to think carefully about what's available in our territories. We have to think about the socioeconomic restrictions that there may be on some of these drugs. Some of these are available in some territories, all of them are available in other territories, and I think we have to fit our algorithm according to what's available in our own countries. Now, we have just completed guidelines for relapsed and refractory DLBCL, trying to be pragmatic and applicable for many territories. And I'm going to take you through the algorithm over the next half an hour or so, and provide you with the evidence base that demonstrates why we put various things in different places, and perhaps some of the options that we could consider if certain options are not available. So we have a patient with relapsed and refractory DLBCL, and I think there are two important questions that we have to ask. Number one, is this patient fit for intensified therapies? And number two is, how early has this patient relapsed? Then we need to think about what's available in our territories. So the standard of care for patients with relapsed refractory diffuse large B-cell lymphoma over the last 25 years or so has been reinduction with non-cross-resistant immunochemotherapy and consolidation of that response with high-dose chemotherapy and stem cell rescue. Now, the outcomes for patients with early relapse have been disappointing, and the CAR T cells in some territories are trying to fill that space, and I'm going to come back and talk to them. But actually, if you don't have CAR T cells available where you work, this remains the best option for your younger, fitter patients who are able to undergo the rigors of high-dose chemotherapy and stem cell rescue. Now, it takes us back to the 90s to the days of the Palmer trial, which provides us with the randomized evidence to demonstrate that this approach of reinduction chemotherapy, followed by consolidative high-dose chemotherapy and stem cell rescue, is associated with both a progression-free and overall survival advantage, and that those patients treated with chemotherapy on their own, unfortunately, their outcomes are disappointingly poor. So if we think the patient is fit enough to get to high-dose chemotherapy, then that's absolutely what we should try and achieve. But the key test here is that patients must be chemosensitive. For offering high-dose chemotherapy and stem cell rescue in patients with aggressive B-cell lymphomas who are not chemosensitive does not confer benefit, and patients just get a lot of toxicity without good outcomes. Now, what chemotherapies do we use to get to the patient into a second remission? Well, there are various different recipes. You'll know of R-ICE, R-DHAP, R-GDP, R-ESHAP, etc. And I think that they have slightly different chemotherapy drugs within them. They're all essentially have a platinum-based backbone, and essentially they try and achieve three things. Number one is to get the patient in the best possible remission. It's great if we can get to the patient to be in a complete remission by the time we offer them high-dose chemotherapy and stem cell rescue. Number two, we want it to be of modest toxicity and have little time in hospital, because we want to make sure that the patient is fit enough to be able to undergo high-dose chemotherapy stem cell rescue. We don't want them to lose performance status whilst their disease is still responding. And the third thing to say is, of course, we want a regimen that is not going to compromise the delivery of stem cells, which we're going to be able to use to support high-dose chemotherapy. There's a very key study called the CORAL study, which was conducted across a number of collaborative groups that looked at comparing two different regimens to see if there was any difference in the outcome. The comparator was R-DHAP to R-ICE chemotherapy. High-dose chemotherapy and stem cell rescue was offered to responding patients, and you can see that there was no difference in outcome according to the induction regimen. A similar study compared DHAP with or without rituximab and GDP, so gemcitabine, dexamethasone, and cisplatin, and this was performed by the Canadian collaborative group, and you can see that there's no difference in progression-free and overall survival. Now, GDP is given as an outpatient regimen, and that has very many attractive advantages, obviously, for the patient, although there is a return visit on day 8. And we saw that in patients treated with GDP, that their quality of life was better than the quality of life of patients treated with DHAP chemotherapy. And so for that reason, our GDP is probably one of the main reinduction therapies that are used for patients with relapsed and refractory diffuse large B-cell lymphoma. We've looked at trying to partner a different antibody targeting CD20 to the chemotherapy backbone to see if this in any way overcomes resistance. If you think about these patients, they've already been exposed to rituximab. So if we use a different anti-CD20 that targets a different epitope on the cell surface, CD20, then we might get better outcomes. And the Orchard study compared chemotherapy with DHAP to R-DHAP to ofatumumab DHAP, and ofatumumab was a previous generation of CD20 monoclonal antibodies. Big randomized study, and you can see from those curves, the ofatumumab patients are in the gold, the rituximab treated patients are in the blue, and you can see that there's no difference in outcomes, unfortunately. Now, we often get the question is, how much chemosensitivity do I need to deliver in order to be able to proceed to high-dose chemotherapy and stem cell rescue? Well, I think if we look at patients who have a partial response, and we look at a PET positive partial response in patients, we recognize that some of these patients can do very well. And this is retrospective data from the CIBMTR registry, 250 patients in PET positive partial response. And you can see that their progression-free survival is 40% and overall survival some 50%. So I absolutely think that this is worth offering to patients who are in partial response. But I think partial response means a different thing to different people. And there are some patients who still have a significant disease burden but are called a partial response. And there are, of course, patients who may just have one small area of residual avidity who are also called a PET positive partial response. So this is very important in terms of individualized decision making as to whether you decide that the response has been adequate, the patient has been suitably cytoreduced before you think about reinduction, you think about consolidation with high-dose chemotherapy. Often my approach is to take patients who have got small residual areas after reinduction therapy and to offer consolidative radiotherapy after they've had high-dose chemotherapy and stem cell rescue. So certainly complete response patients and some PET positive partial responses. And I do recognise that this data is in very many ways a selected group of patients. What about offering high-dose chemotherapy to older patients? We've been pushing up the upper limits of age group for offering high-dose chemotherapy, and it's not altogether uncommon in our practice to be meeting patients now over the age of 70 who we are thinking about considering for reinduction therapy and consolidation with an autograft. And you can see in this group of patients, it's 63 patients over the age of 70, and then they have a progression-free survival of nearly 60% and good overall survivals. Higher non-relapse mortality than we would normally expect with this approach. And I think what's really important is about individualized decision making. And I think it's really important that you think about the comorbidities of the patient, the functional status. And I think what's really important is the trajectory of functional recovery. If you offer autologous stem cell transplantation to a 30-year-old, it's going to take them a number of weeks, 6 weeks or so to get back to normal. But often for patients over the age of 70, often their recovery periods are prolonged and maybe very many months. And we need to think about that when we're deciding to offer this to older patients. So I try and do this in discussion with my colleagues in the Medicine for Older Patients service to make sure that we get the decision right. And I think this is very much one of the shared decision making where you talk to the family at length about the risks / benefits of this approach. Now, unfortunately, we see a group of patients, who benefit poorly from reinduction therapy followed by autologous stem cell transplantation. And the biggest risk group is those patients who relapse with less than 12 months from their completion of their induction R-CHOP or whatever induction regimen that we plan to use. And unfortunately, in the era of rituximab, those patients who relapse within 12 months, unfortunately, their event-free survival is somewhere in the order of about 13%. So this group of patients are not well served by this approach of reinduction chemotherapy followed by stem cell rescue. Now, I will say, it's not likely that the high-dose chemotherapy is the point of failure. The point of failure is our induction chemotherapy regimens. And actually what we want to do is make our induction chemotherapy regimens better so that we get more patients to have achieved a response who can then undergo high-dose chemotherapy and stem cell rescue. These are the outcomes for patients who have early relapse disease or refractory disease who got to the point of autologous stem cell transplantation. And you can see that both their progression-free survival and overall survival are much better than would have been expected from the data that was seen in the CORAL study. The main reason that patients have such a poor event-free survival in the reinduction regimen is because the induction therapy, the ICE, the DHAPs, the ESHAPs, are generally not good enough. And so we want to make those better. I don't think that the autograft is the main point of failure. And we recognise that if you can get the patient into remission first time round, then their responses are better rather than having to use a number of systemic therapies to get you there. And this is data that we've just seen from the Spanish group, which looks at the outcomes for patients who get to stem cell transplantation. We can see this is a massive group of almost 800 patients. We can see in those patients who got to stem cell transplant in CR, they're demonstrated in the blue curve, and they have a 6-year progression-free survival of 56%. For those patients who went to stem cell transplant in partial response, their 6-year progression-free survival was 43%. And this included patients who had both early relapse and late relapse, and really demonstrates that the auto is clearly a curative option for patients with chemosensitive disease, especially those achieving a CR, regardless of the timing of relapse after frontline therapy. So although you'll see lots of excitement around CAR T-cell therapy for selected groups of patients, remember that the autograft absolutely is a very strong component of therapy, and you shouldn't think about completely abandoning this. Now, for those patients who do fall into that high-risk group that we recognize who relapse within 12 months of first-line therapy, and we know that the induction therapies are going to be tricky to get them into remission to ever think about an auto transplant, is we should ideally, if available, offer these patients CAR T-cell therapy. Now, of the CD19-directed CAR T-cells that are available in some territories, they're not available in all territories. For example, in the UK, I only have the choice of axicabtagene. I certainly know that in India, you've got some home-developed CAR Ts that you are examining further. I certainly think that these are a really highly effective modality of treatment, and we recognize in the setting of multiple relapsed patients from the Zuma-1 study that an overall response rate was seen in 3/4 of patients, with actually 60% of patients achieving a CR. And what's important about the responses that we see from CAR T-cell therapy is that it appears to be durable. And once we get past the 6-month inflection point, we recognize that relapse events are very uncommon. And if we look at the long-term follow-up data now at 5 years, from patients treated in the pivotal Zuma-1 study of axicabtagene, we can see that 43% of patients who were reinfused were alive at 5 years from diagnosis. And that's a remarkable turnaround as to what we've been able to achieve previously. But we recognize that this is in a highly selected group of patients. Now, of course, based upon this data that we have seen, so giving CAR T-cell therapy, however, is complicated, and we recognize that there are very many challenges. Not least, there are simple practical challenges around the undertaking of the procedure. Patients need to undergo apheresis. They may need to have bridging therapy during the manufacturing process. It's interesting to talk to colleagues from the US, where they say the manufacturing process takes somewhere in the order of 15 to 16 days. For Europe, for example, the manufacturing process takes much more like 28 to 35 days. The patient then has lymphodepleting chemotherapy, reinfusion of their CAR T cells, and generally has to stay in hospital for about 2 weeks after the reinfusion, but sometimes longer, and certainly near the hospital site for the first 28 days afterwards. And then follow-up is complicated after CAR T cell therapy. So I often get frustrated when I hear people talking about CAR T cell treatment as a one and done treatment. It couldn't be further from the truth, because there are so many complicated steps in the delivery of CAR T-cell treatment. We think about bridging therapy. We recognize that holding patients, maintaining performance status whilst we wait for manufacturing of the CAR T-cell is challenging. We recognize if we do give patients bridging therapy, then we recognize that they might have better outcomes, and certainly they may have less toxicity. With the increasing use of polatuzumab in the first-line setting, what we often used as a powerful tool to bridge these patients, unfortunately, has become less so, because many of these patients have been exposed to polatuzumab in the first-line setting. And remember, they're patients who are chemotherapy refractory, so getting a response from giving additional chemotherapy is difficult. And certainly we have used much more radiotherapy to help bridge our patients in that time interval between apheresis and the product becoming available to us. Now, of course, based upon the success of CAR T-cell therapy in the third line plus space, it was of course only natural to ask the question, how effective are these in the second line space, and particularly can they help us in those really difficult group of patients that either have primary refractory disease or who relapse within 12 months of completion of therapy. Now, the 3 studies that were randomized compared standard of care reinduction with immunochemotherapy, followed by high-dose chemotherapy and stem cell rescue, to CAR Ts. I've just put a study schema up of Zuma 7, where the CAR T that was being examined was axi-camptothecin. And they had slightly different endpoints, but essentially the primary endpoint was event-free survival, but the definitions of those were slightly different across the studies. And of course, this will be familiar to you. This is the result of the Zuma 7 study. So these were patients who'd all relapsed within 12 months of completion of their primary therapy. We can see event-free survival at 24 months for patients treated with the standard of care was just 16%. So exactly as we talked about from the CORAL study, rather than those patients who received axi-camptothecin, where their event-free survival was almost 41%. So superiority in the primary endpoint for this study. And I think why this data is very important and why it's caused practice change in many territories is because, of course, it wasn't just an event-free survival outcome. It was also associated with an overall survival outcome, despite the fact that many of the patients who were on the standard of care arm received CAR T-cell therapy in the third line space as not as part of the protocol, but off study. And we can see that the use of CAR T-cells was associated with a 27% risk in the reduction of death compared with the standard of care approach. Now, that's the story of axi-camptothecin. The story with lisocabtagene, which is also a CAR T-cell product, different manufacturer, not quite so widely available at the moment, and also, importantly, a mixture of CD4 and CD8 in a specific ratio. And we can see that this study was associated, again, with an event-free survival advantage. There isn't actually a statistically significant overall survival advantage because of the and we won't see that because the alpha has been spent on doing this. But you can see that there is a separation in the curve. The advantage with the lisocabtagene is perhaps it has a more favorable safety profile with less grade 3 for ICANS and CRS. And the third of these randomized studies was the Belinda study using T-cell from another manufacturer. The endpoints here were different. The time to delivery of the product was much longer, and we can see that there was no advantage of the CAR T-cell product over standard of care. So, if you look at all of this data together, you look at a meta-analysis comparing CAR T-cells to reinduction chemotherapy with stem cell rescue, we can see that the meta-analysis favors the use of CAR T-cells if they are available to you. Now, of course, there are very many challenges in the communities that we work in terms of delivering CAR T-cell therapy for patients. Number one is the time it takes from the apheresis procedure to the return of the CAR T-cell product. And we can see that those patients where it takes more than 40 days, vein to vein time, have worse overall survival. And so patients are dying whilst they're waiting for CAR T-cell delivery. We recognize that there are very many acute toxicities associated with CAR T-cell reinfusion, and those toxicities are associated with significant resource utilization and significant morbidity and mortality. And, of course, the management of cytokine release syndrome, often we're seeing grade 3 cytokine release syndrome, or the management of the neurological toxicity, including the possibility of intensive care and all the support that requires, is a massive problem in terms of the way we design our services and the resource utilization that there is as a result. And we recognise that the cytokine release syndrome and the ICANS comes generally within the first 2 weeks after reinfusion of the CAR T cells. And we recognise that both of those often come hand in hand. So those patients who get high-grade cytokine release syndrome are very often the group of patients that get a high-grade neurological toxicity. And we recognise that if you do get severe toxicities from CAR Ts, then that does compromise your mortality and your outcome. So having these high-grade toxicities is not good for patients. We also recognise that after having had those acute toxicities, patients develop cytopenias, and sometimes those cytopenias can go on for very many months. And those cytopenias require quite a lot of hard work from our delivery teams. So they require blood product support, growth factor support, erythropoietin, GCSF, etc., and often multiple admissions because of pancytopenia, because of the patient has infective episodes. And as you can see, that there's a group of patients where this can go on for very, very many months, and it can be really very difficult indeed for these patients. And not only do we have the cytopenias, but of course we have the B-cell aplasia, and the B-cell aplasia results in hypergammaglobulinemia, infections, and often the use of immunoglobulin replacement, which of course has very many resource utilization problems. And increasingly, we are seeing challenges with long-term infections in patients who've undergone CAR T-cell treatment. And so whilst we may see bacterial infections during the acute phase of the illness, we can see a significant risk of mortality from respiratory virus infections in the very many months after people have had CAR T-cell therapy. So whilst their risk of recurrence of lymphoma may reduce after 6 months, actually their risk of dying from an infective complication continues and can continue for very many months. On top of that, we have got new data demonstrating that there may be a increased risk, I use the word risk in quotes, of T-cell malignancies in patients who have received CAR T-cell therapy, both the BCMA directed for myeloma or CD19 in those patients for lymphoma. Now, we recognize the numbers are small. We're trying to work out the biology of why this should happen, but it's another thing that you need to add into the conversation when you're talking to patients about CAR T-cell therapy. So all of that together tells me that there are very many challenges. These challenges are not only about giving our teams the knowledge to safely deliver CAR T-cell therapy and to be able to look after patients who have had CAR T-cell therapy. We need to make sure that we are allowing patients to have access to CAR T-cell therapy, and that is certainly very challenging when this is only being conducted in generally very small numbers of centres so far. Often patients, even if they are socially or economically mobile, often they have to travel very long distances from their referring centre to a CAR T-cell infusion centre. The cost of CAR T-cell is prohibitively high. There's of course the direct product cost, but also the cost of hospitalisation, medication, and a range of non-medical costs. And some insurance organisations or services, national services are providing this, but actually a lot of them are not able to do this. And of course, there's a great degree of coordination in terms of this. And despite all of these challenges around CAR T cells, we're still seeing a lot of patients who are being failed by CAR T cell therapy, either because of loss of target antigen expression or because of exhaustion of the T cells. So if we think about the challenges of CAR T cells, is that, although there appears to be some curative potential, the delivery is very difficult, and there are very many challenges around the upfront commitment from patients and caregivers, and the availability of it across territories, and also the high socioeconomic costs of CAR T cell treatment. Now, just before I leave CAR T cells, what I also just want to address the question of patients who achieve a CR with their bridging therapies. Are those patients still ones that can benefit from CAR T cell therapy, or should we think about abandoning the fact that they've had a CAR T manufactured, and we should go on to consolidate those with high-dose chemotherapy and stem cell rescue? Well, the answer to that is we don't know. But what we do see is patients who go into CAR T cell therapy in complete remission are still at a risk of relapse at a very similar rate to ones that are going into a partial response. So I think we don't know the answer. If you've got a CAR T cell product manufactured for that individual, then generally I would give that, but I don't think it's wrong if they do achieve a CR to offer those patients an alternative consolidation approach. So that covers the fitter patients at first relapse, depending upon the availability of different regimens. What about the unfit patients, or ones where trying to access some of the more intensive therapies can be challenging? Well, there's a range of different options, and traditionally we have used a reinduction chemotherapy that's gentle, easy to give, and hopefully with low toxicity. And some of those regimens you'll be familiar with: rituximab, gemcitabine, and oxaliplatin, or bendamustine and rituximab. And this is just registry data. We see response rates of probably about 50% with these combinations. We can generally give them quite safely, but unfortunately you can see in terms of the direction of the curve that actually their outcomes are generally poor, and there are few long-term survivors when we use these palliative chemotherapy regimens. And all of you will have your own favorite approach, and there's a long list of potential chemotherapy regimens that you might wish to use in this sort of intensified therapy unfit patient population. Now, I want to just spare a few moments just to talk about the impact of antibody drug conjugates. And polatuzumab vedotin is an antibody which targets CD79B, which is a component of the B-cell receptor. Through a cathepsin B sensitive linker, a cytotoxic agent called monomethyl auristatin, MMAE, is linked to the antibody. And this antibody drug conjugate is able to deliver cytotoxic therapy directly to the malignant B cell. So what happens is that when the antibody drug conjugate is given intravenously, it seeks out CD79B on the surface of the B cell. It causes internalization, where the MMAE is cleaved from the antibody. The MMAE is released, causes microtubular disruption and apoptotic catastrophe. Now, we're all familiar with MMAE. We use this in brentuximab vedotin for the treatment of Hodgkin lymphoma and anaplastic large cell lymphoma. And this antibody drug conjugate polatuzumab is quite useful on its own. It has some modest activity, and when we add rituximab to it, the more activity increases. But the number of patients who achieve a complete remission with polatuzumab and rituximab is very low. And you know that the best way to achieve durable benefit in patients with diffuse large B-cell lymphoma is to sort of strive for the holy grail of having a complete remission. So the strength in polatuzumab has come from adding it to chemotherapy. And in the pivotal trial, polatuzumab was added to the bendamustine and rituximab backbone. Now, that was chosen over GemOx as the backbone because there was concern about overlapping toxicity of the oxaliplatin and the polatuzumab, the MMAE on the polatuzumab. So the randomized study, it was a small study, compared patients receiving bendamustine and rituximab to patients receiving pola, BR, and the primary endpoint was PET-defined complete response rate. And that increased from 17.5% in the chemotherapy rituximab treated patients to 40% in those patients treated with pola BR. And this was associated with a threefold increase in both median progression-free survival and overall survival. Now, this is an important option, I believe, for patients who are ineligible for CAR T cells or ineligible for autologous stem cell transplantation. We really are cautious about the use of bendamustine in patients where we think we might want to use a cellular therapy option, because of course bendamustine can damage over a long period of time your T cell function and can affect your stem cell harvest yields. So this is for an option for patients where the intensive treatments, the cellular therapies, are not an option. Tafasitamab is an antibody which targets CD19 on the surface of the malignant B cell. It has some humanized functions, which means it's very good at antibody-dependent cellular cytotoxicity, and is given in combination with lenalidomide, which enhances NK cell activation, which improves the ADCC activity. And in a pivotal trial that took a selected group of patients with DLBCL, there were very few patients with refractory disease, so we have to interpret this data with some caution, that the Tafa-Len combination resulted in an overall response rate of 58%, with 33% of patients achieving a complete remission and a 12-month progression-free survival of some 50%. I will say that the real-world data with tafasitamab has been much more disappointing, and I think that's a reflection of the fact that more patients with resistant disease have gone on to receive therapy. But no doubt tafasitamab and lenalidomide is useful for some of our patients, particularly the older patients who have got disease that has demonstrated prior benefit. It can be quite useful for a group of patients. So those are our potential options in the second line setting. For those patients who've had a reinduction chemotherapy with a stem cell transplant and relapse, then we can offer those patients CAR T cells in the third line setting if they are available. If their CAR T cells are not appropriate because the patient is unfit or the patient has had prior CAR T cell therapy, there are a number of other agents that one can think about in the third line space. And I think that we are all very excited about the data surrounding bispecific antibodies, which I'm going to come on to later. But do think in the third line space about palliative radiotherapy for patients, using other chemotherapy regimens that you may not have used previously. And I will come back to the role of some of these other things as I go through the last section of my talk. Now, bispecific antibodies in diffuse large B-cell lymphoma are clearly causing a lot of excitement. We recognize that these bispecific antibodies have at least 2 antigen targeting sites in their construct. Some of them, such as glofitamab, may have 2 sites for one particular antigen. And they simultaneously target CD3 on the surface of the T cell, and they also target CD20 on the surface of the malignant B cell. And with this simultaneous targeting, they bring the T cell in close apposition with the tumorous B cell, and they're able to form an immune synapse. And the formation of this immune synapse and release of various cytokines basically induces effector T cell death without the need for MHC-mediated antigen presentation. And in diffuse large B-cell lymphoma, the 2 products that are pretty much have marched ahead in this field are epcoritamab and glofitamab, which I'm going to talk a little bit more about in the next few minutes. Now, why are we keen to think about bispecific antibodies? And we can briefly compare these to CAR T-cell therapies. We can give bispecific antibody therapy immediately. I can see a patient in the clinic, and in the afternoon, I could have started their bispecific antibody therapy. We don't need long manufacturing times. We don't need lymphodepleting chemotherapy. And as I say, they're off the shelf, and we can deliver these in community hospitals. We know that they work quite quickly, and we recognize that they are effective also in older patients. And there's just a few key principles that I want us to think about as we talk about bispecifics. Unlike CAR T-cell therapy, whilst we do see cytokine release syndrome because of T-cell activation with bispecifics, the cytokine release syndrome is typically low grade It's pretty predictable and can be mitigated by step-up dosing. So what does that mean? Well, it means that the majority of patients have grade 1 cytokine release syndrome, which is simply a temperature. We recognize it's most likely to occur either with the first exposure of the bispecific antibody or the first full dose exposure to the bispecific antibody. And that's different according to the products, and that's about familiarization with the product that you're using. And by starting with a small dose initially and building up the dose to the target dose over a number of weeks, this can reduce the risk of cytokine release syndrome. This is T-cell effector therapy, so neurotoxicity has been reported, but generally this is uncommon and is generally very low grade. And I think if you see patients with neurological toxicity neurological symptoms who are having bispecifics, don't automatically leap to the thought that this is an ICANS. Think about other things such as, is this progression of disease in the CSF, for example. We can deliver therapy almost entirely as an outpatient regimen. You may need to come in to the first full dose, but that's a short stay, overnight, 24 hours. We can deliver this in community hospitals. We do need to train our teams to some degree to recognize the toxicities, but we don't need to undertake the degree of training that we do need to set up CAR T-cell therapies. And that between the bispecifics, there's some differences in delivery modalities and the therapy duration. So I'm just going to spend a little bit of time just giving you the pivotal data for the two bispecific antibodies that are in the most advanced stage of delivery. And the first of those is glofitamab. And glofitamab has two CD20 binding sites on the antibody and one CD3 binding site. And the pivotal study looked at 154 patients who had had 2 or more prior lines of therapy for diffuse large B-cell lymphoma. You can see over on the right-hand side how the step-up dosing goes. They start at 2.5 milligrams, then 10 milligrams. Then by the time they're going to start cycle 2 of 21-day cycles, they're at 30 milligrams, which is the top target dose. Patients are also given in the week prior to starting glofitamab, a loading dose of obinutuzumab. This is a third-generation anti-CD20, which saturates the CD20 binding sites and is given to reduce the risk of cytokine release syndrome. If you look at the curve, the graph over on the left-hand side, you can see the cytokine profile of patients treated with glofitamab. You can see rapid rises in a variety of cytokines that fall over time. If you give patients glofitamab as a pre-treatment, you can see that we don't see these peaks in releases of various different cytokines. So this is a really important mitigation factor for cytokine release syndrome. So 154 patients in the pivotal trial, all with 2 or more prior lines of therapy for diffuse large B-cell lymphoma, a small number of patients with high-grade B-cell lymphoma and primary mediastinal B-cell lymphoma, and 2/3 of patients who previously had CAR T-cell treatment. We can see that they were tough because 85% of patients were refractory to their last prior lines of therapy. The take-home message is that the complete remission rate was 40%. So this tough crowd of patients, we can see the complete remission rate was 40% across all patients. And the median duration of the complete remission for those patients who obviously achieved a complete remission was some 30 months. So we can see that those benefits appear to be durable. And we can predict how patients are going to do. We might be able to use this as a way of making sure we appropriately select therapy for patients. And we can tell how well we're doing by the time we get to cycle 3. And so those patients who are in complete remission by cycle number 3 are going to do really well with a progression-free survival at 24 months of 64% and an overall survival of some 75% if they're in CR by cycle 3. Those patients who achieve a partial response only by cycle number 3, unfortunately, their outcomes are very poor. And so I think what the clear message here is, although there are a few patients who may get longer-term benefit, you can really tell quite early who's going to do well and who's going to benefit long-term from the the bispecific antibody. Not unsurprisingly, those patients who have a high total metabolic tumor volume going into bispecific antibody therapy, as shown in the red line, are going to do less well than those patients who've got a lower total metabolic tumor volume, shown in the blue line. And we can also use total metabolic tumor volume to evaluate the risk of cytokine release syndrome. So here is the toxicity. Okay, 63% of patients are going to develop cytokine release syndrome, but almost all of those, so 50% of those, 50% of, in total, 50% is going to be grade 1. The 50% of the 63%. The numbers of grade 2 or grade 3 cytokine release syndrome are really very small indeed. And remember that grade 1 cytokine release syndrome is simply having a temperature over 38 degrees. Now, epcoritamab is an alternative anti-CD20 monoclonal antibody, and this is given by the subcutaneous route. And that has some advantages, certainly for some patients. Their study design was almost identical and had a similar number of patients, many of those with the same risk features. The most important thing to say is that cytokine release syndrome occurred at a slightly different time, and actually it occurred with the epcoritamab when patients received their first full dose. And so this is on day 15 of the first cycle of therapy. But once again, you can see that those patients who do develop cytokine release syndrome, almost all of it is simple grade 1 cytokine release syndrome. The response rates are very similar to what we've seen with glofitamab. The complete response rate was 39%, and patients with across the ages, across different diseases, different types of large cell lymphoma, according to numbers of lines of therapy and previous CAR T-cell therapy or not, very similar complete response rates. So it doesn't look like prior therapies affects the efficacy of the bispecific antibodies. And we can see once again that those patients in the green line who achieved a complete remission are the ones who get the long-term benefit from this therapy. Now, you may think, but I've got two different drugs that are both exciting in terms of their efficacy in patients with difficult disease. How do I choose between them? Well, there are some differences that we need to think about, and we may need to think about our patient-related factors and obviously our resource factors about how we want to do this. But epcoritamab is given as a subcutaneous injection, and the subcutaneous injection is given weekly for the first 12 weeks, then fortnightly, and then it becomes every 4 weeks, but is given until disease progression. The hospital stay is on the 3rd week of treatment, and the time of delivery is very short indeed because it's a subcutaneous injection. Glofitamab is an intravenous infusion. We give it slowly in the first weeks and have an observation period afterwards, but as we get past the step-up dosing and patients have tolerated it well without cytokine release syndrome, we're able to make the infusion much quicker. The advantage with glofitamab, however, is its fixed duration therapy. It's given for some 12 cycles, which takes the patient over just 8 months worth of treatment. And so there's a difference about how you might want to look at this according to the choices that you want to make for your patient. So, okay, we've kind of pulled out some of the differences between CAR T-cell therapy and bispecific antibody therapy and some of the significant advantages of bispecs over CAR T-cell therapy, and we can try and look at the efficacy to see where we are in terms of helping us make choices. And you can see that probably the efficacy in this 3rd line setting for CAR T-cell therapy is probably modestly greater than the efficacy for bispecific antibodies. And recently we've seen a meta-analysis published in Blood demonstrating that clearly the efficacy is better from a pooled analysis for CAR Ts over bispecifics, but it's marginal. What's very clear, however, is that the toxicity profile for the bispecific antibodies is much better than the toxicity profile that we see with CAR T-cell treatment. So you can see over on the right-hand side with the the grade 3 or greater cytokine release syndrome with the CAR Ts occurs in 8%, and only 2% of patients with bispecs. 11% get grade 3 or greater neurotox, compared with 1% of patients with a bispec, etc. And infection appears to be much greater. Now, what about sequencing? If these therapies are become more broadly available, how are we going to make our choices? Well, we've seen some data from the French to say that patients who have had CAR T-cell treatment and then relapse after CAR T-cell treatment, they can certainly get benefit from the use of bispecific antibodies. And conversely, we can see some data that's come from the Barcelona group that demonstrates that patients who've had prior bispecifics, it doesn't have any impact upon the efficacy of CAR T-cell treatment. So I think what's really important here is that exposure to a bispecific doesn't impact upon CAR T-cell efficacy. The response to a prior bispecific is not predictive of the response to CAR T. So just because you may not have responded well to a bispecific doesn't mean that you're not going to respond well to CAR T cell therapy. And also, I think independently, the risk of cytokine release syndrome from the bispec and the risk of cytokine release syndrome from the CAR T cell don't seem to be related. So I think you can safely use these in whichever sequence you think is right. I think we like to use CAR T cells if they're available first, because I think we've got more long-term follow-up data, but that's really beginning to change now. So there's a big focus on improving the efficacy of bispecific antibodies. So there's a big focus on combination. This is just some data of the combination of the bispecific antibody with polatuzumab in a tough group of patients. And this no doubt increased the overall response rate and complete response rate. So the complete response rates were almost 60% compared with the 40% response rates that were seen with the bispecific antibodies on their own. And there are now a range of different second signal molecules that are being given with the bispecific to enhance the T-cell response when we give the bispecific. And the preliminary data that we're starting to see again suggests that these dual targeting approaches of the T-cell may improve the complete response rate. So watch out for some of these molecules coming soon. And I think this year we've seen the most important data in terms of the proof of principle of giving a bispecific antibody with chemotherapy. Now, I have been somewhat concerned that the effect of the chemotherapy might attenuate the T-cell response to the bispecific antibody, but the results of the STARGLOW study certainly have proved us wrong. Of patients who had previously treated diffuse large B-cell lymphoma, so they were treated at second or third line, they were thought to be ineligible for stem cell transplantation, and they received either R-GemOx, so rituximab, gemcitabine and oxaliplatin, or the GemOx chemotherapy backbone with glofitamab, and the randomization was 2-1. And I think the results have been really quite incredible. And these are curves not of progression-free or event-free survival. These are overall survival curves. The top green demonstrates those patients receiving the bispecific antibody with GemOx. The blue curve is the outcome for those patients receiving R-GemOx. And the hazard ratio on these curves is 0.62. So what that means is that by using a bispecific in combination with GemOx, there's a risk of reduction of death by some 38%. These are not surrogate endpoints. This is death. And I think we can really feel that there is a clinically meaningful overall survival benefit from the addition of the bispec. And I think this is going to be very important data. We can see that the effectiveness in the second line setting and the third line setting is very similar. And you can almost convince yourself that there's a plateau on that upper green line in terms of overall survival outcomes. So I think that we're going to be increasingly thinking about using this in our therapeutic armamentarium for DLBCL. So just in the last minute or so, I want to introduce you to a couple of other agents. Importantly, loncastuximab is another antibody drug conjugate which targets CD19 on the surface of the malignant B cell. This takes a different type of cytotoxic payload called PPD. It has a distinct protease cleavable linker that links the PPD to the antibody. It's given every 3 weeks as an infusion. They're given 2 higher doses initially, then followed by a maintenance treatment, and it's given for up to a year. And in patients with relapsed and refractory DLBCL, the overall response rate was 48%, with 24% of patients achieving complete remission. This is a very well tolerated drug. It does, however, have a pattern of toxicity that's somewhat different to the toxicities that are seen with other antibody drug conjugates, and that's because the cytotoxic payload has some distinct features that causes peripheral edema and edema including pleural effusions. It also causes a degree of hepatotoxicity, and very importantly can also cause a photosensitive rash. And when we first started using this, we weren't quite so good in the education piece around sun exposure, and we'd have a lot of patients who sort of stuck their elbow out of the window whilst driving and got terrible photosensitive rashes. So if you're going to use this, give the patient some sun cream as well to take home. So I think this is an important drug to think about in our armamentarium. And that just demonstrates that some of those responses are certainly durable in the pivotal population. So, in conclusion, the results from conventional chemotherapeutic approaches unfortunately have been very disappointing in relapsed and refractory DLBCL, but certainly there's still a role for fitter patients who can achieve a remission with reinduction chemotherapy or high-dose chemotherapy and stem cell rescue. I absolutely spent a lot of time at that at the beginning because I don't want you to think it's all about CAR T cells. There's no doubt that CAR T cells are useful in some limited clinical situations. However, there are very many challenges around delivering CAR T cell therapy, not least the economic impact. There's huge promise from bispecific antibodies, and we're starting to get increasingly familiar with those. We're seeing a data set that's starting to expand, and I think that we're particularly interested in the combination of bispecific antibodies with chemotherapy. We may even see the results of these in the first line setting, and again, a massive change in our algorithm. We've got a lot to do in terms of being able to ensure that we use this new armamentarium of drugs for diffuse large B-cell lymphoma in the correct way, and that we get the sequencing right. Thank you very much for listening. I really hope that was informative, and I look forward to your questions.
Thank you so much, Dr. Andrew Davis, for this fantastic lecture. As always, it's worth to listen to you. Thank you a lot. And I now request all our discussants to please put the raising signs so that we can start our question and answer session with Professor Dr. Andrew Davis. Yes, we have first Dr. V.A. Arun. Please go ahead.
Good morning, Dr. Andy, for a wonderful talk. I had 2 questions for you. One is with respect to the polatuzumab. We in India have issues with access to it, but we do have access to it. So I had 2 points. One is a philosophy, whether we use polatuzumab as a standard of care in the first line, maybe in some of our patients, or should we use it as a bridge to transplant like Pola Rise platform that actually gives you good responses? So what is your take on that, whether Pola should be utilized? Because we don't want relapsed refractory disease, or if we have refractory or relapsed disease, we treat them well in the second option before we take up the patient for a auto transplant. My second question was theoretical one, in the sense that if somebody progresses on CAR and is eligible for a curative therapy, would you go for an allogeneic transplant or a bispecific? What would be your choice like in such a patient?
I think those are 2 really brilliant and important questions. So I believe that DLBCL, we should give our best therapy first. And I think we should really do our best to try and cure people with the first line settings. So whilst I describe a very exciting landscape of drugs that can be used in patients with relapsed and refractory disease, those drugs are unfortunately disappointing in their efficacy. So we still see a lot of patients who are failed by any of these new drugs. I believe that the polatuzumab can help in the first line setting, prevent progressions for patients, and therefore prevent the need to have second and subsequent lines of therapies that are economically very expensive. They are socially very difficult because patients often have to be away from home for a long time, and unfortunately they're not as successful as we would like them to be. So for patients who are able to access polatuzumab, then I would recommend using that in the first line setting. And we know that the patient group who you particularly want to think about are those patients who've had the highest IPIs, so 3 to 5 IPIs, those patients who have a non-GC immunohistochemical phenotype, and possibly those patients who don't have bulk. So I would say if I could possibly use polatuzumab in the first line setting, I'd like to use it then rather than using it further down the line. Because whilst BR Pola is a regimen that is associated with a 40% complete remission rate, that means you're giving it to a lot of people that it's not working for. And we recognize that even though it pushes out progression-free survival, all of these patients generally fail. So if your strategy, if at all possible, and your patient can access it, then I would like to use the Pola in the first line setting. So then the next question is, what do we do for patients who have a CAR T and who are failed by the CAR T cell therapy? What do we do next? Well, a little bit of both of those options, actually, to be quite honest. So for those patients who failed CAR T, I do feel that giving more chemotherapy is generally not very helpful. These patients are generally not chemotherapy sensitive because we've used the CAR T either because they've relapsed early, or they've had multiple lines of therapy, including high dose therapy. So using more chemotherapy is not particularly helpful. So I like to use a bispecific in that setting. Now, for those patients who are younger, who achieve a response with a bispecific antibody, then we recognize that those patients eventually are going to fail, despite the fact that we know that the durability of the benefit from the bispecific looks to be good and long. If they're in their 30s or their 40s, I can't believe that the bispec's going to keep that going for the rest of their lives. So for those patients who achieve a response from a bispec and who are younger and fitter, I have a conversation with them about allogeneic transplantation. Okay. Now, not all of those want to do that, but there's a possibility. For those patients who are older, where the mortality from allogeneic transplantation becomes unacceptably high or too high in the patient's opinion, then we give the bispecific antibody, and if we're using a specific antibody, we then stop and we observe them and we see how we go. So that's my approach to relapse post-CAR T. The number of patients who go on to have allo transplant because the kinetics of the disease, etc., are relatively small, but it certainly has been a successful strategy that we've employed.
Thank you. Any other question, Dr. Arun?
No, thank you.
Sir, from the same note, what Dr. Arun has asked, if the patient has to be taken for transplant, in a salvage setting, can we go for Pola-based plus ice?
Oh, yeah, sorry, I meant to say that. Yeah, I'm really sorry. So I'm really interested that we've seen the data from this small single-arm study of Pola R-ice that looks very interesting and effective. We, in collaboration with the German lymphoma group and the Spanish and the Austrian group, have conducted a massive study of over 300 and something patients looking at the combination of Pola R-ice randomized against R-ice chemotherapy. And we've got the last 20 patients to recruit. And so we'll look to see, so we'll have some good randomized data to see. And the primary endpoint of that study is failure to achieve a PET-defined CR, basically. So I guess we'll know in the randomized setting how good that combination is. But I certainly think if you've got a young, fit patient who's not been exposed to polatuzumab previously, relapses, then actually it's a good way of being able to do it. We know it's effective, and we know that it appears to be a safe regimen. You can wait and see what the randomization data looks like, but I think using it now is a reasonable thing to do. I will say, however, even though it looked effective in the data the US group published, there are still failures, and there's still a lot of failures. So that's why I would prefer to use my Pola up front. but I appreciate you might use less because you will only use three lots of it.
Thank you, sir. Thank you for that clarification. Dr. Roshni Pandey, ma'am, your question, please.
Good morning, sir. I have a case to discuss with you. This is a doctor friend who is 44-year-old, diabetic and hypertensive, PS of 1. He presented with a stage 2 AEX, diffuse large B-cell lymphoma, GCP type. The disease was in the colosplenic flexure. He had a mass of 13 by 7.2 by 14.8 centimeters, and he received RCHP 4 cycles. After 4 cycles, the mass decreased to 4.75 by 4.8 centimeters. This mass was still infiltrating the anterior pole of the spleen and the greater curvature of the stomach. After that, he was given 2 more cycles of Pola RCHP. And after that, the PET CT done 3 weeks later, still showing about 3.3 by 2.7 centimeter mass with the same SUV max of 8.1. The lymph nodes which were present initially on the baseline scan are non-FDG avid, but the size of the lymph nodes are 2.1 by 2 centimeters. So the question number 1 is, should we go for radiation, and will there be any radiation-induced toxicity? And will this radiation be a bridging therapy to something else? Is this like behaving like a primary refractory DLBCL?
So a good case, difficult one. Obviously, to see residual PET avidity after completion of 6 cycles of polar R ice within a clearly measurable lesion is disappointing. I think you've got 2 approaches. My number 1 would be to have a conversation with our radiology colleagues to see if a biopsy would be possible, to see if there's active residual tumor, because that's your decision process easy. Because I think if you do that and they've got primary refractory disease, then I would offer them a salvage regimen at that point. If, however, the radiologist said to me, well, look, I can't do that splenic lesion, the risk of bleeding is too high, or the lymph nodes are too deep, etc., then I would probably offer that patient radiotherapy if it was readily encapsulable in a radiotherapy field and it wasn't too potentially toxic. I recognise that there may, the British Columbia data demonstrates that that's probably going to be quite a useful thing to do, but we recognise that there is a risk of failure, and I would keep the patient under close follow-up thereafter.
So what do you mean by close follow-up? Will it be PET CT every 3 monthly? I mean, how do we follow them up?
So what I would do is 3 months after completion of the radiation, I would do a PET CT. If the patient was in a CR after completion of radiotherapy, then I would probably do another CT scan or a PET CT scan probably 3 months after that to ensure, and then probably just follow them up clinically. But I would keep a close clinical follow-up rather than just necessarily repeated imaging. I think if people have achieved a CR, then you don't need to do regular serial imaging, even in patients who you think are higher risk.
And supposing he doesn't achieve CR after radiation, then what bridging therapy and then probably CAR T cells?
Well, so I'd have a conversation with the CAR T cell service. The bridging therapy, for second line, is I would generally offer R-GDP or R-ICE treatment. He's already received polatuzumab, so our discussion from the previous question probably isn't relevant, but I would usually use R-ICE in these patients as we bridge them. As I say, we tend, because they're chemotherapy refractory, they tend not to respond terribly well to chemotherapy, and that's why we increasingly are using radiotherapy as a bridging modality, because it introduces a new therapeutic approach.
Okay, thank you, sir. And my second question is, what are exhausted T cells, and when does it happen after the first line, in primary refractory?
Yeah, I think this concept of exhausted T cells is really about saying how well do your T cells respond to antigenic stimulation, and are they able to sort of have a cytotoxic burst, or are they just exhausted? And you can define that by some markers on the surface. What we recognize is if we take CAR the T cells, we do T cell apheresis for a patient, and they've had less exposure to chemotherapy, we recognize that patients are much more likely to have T cells that are fit and are sort of rejuvenated, rather than you taking T cells from patients after having had multiple lines of therapies. So we recognize that patients treated with CAR Ts on the first line setting, they get much greater T cell expansion, they get this huge expansion of T cells, and they probably have a greater efficacy as a result of using patients who have CAR T cells in the third line setting, where we don't see such a great area under the curve or peak expansion of CAR T cells, and we probably see that the efficacy of the CAR T cell is less good in the third line setting as it is in the first line setting. So basically it's the concept to say that if you've got a CAR T that's been exposed to multiple lines of therapy beforehand, it's not going to expand quite so well or continue a response. And I think that's why we're very interested in allo CAR Ts, because of course you're taking T cells from fit patients who haven't been prior chemotherapy exposed, and then they're generally going to be more fit.
And if a patient is exposed to one particular type of CAR Ts with a co-stimulatory domain, which is, and then you expose later, can you re-expose them to CAR T cells with a different co-stimulatory domain, or will that CD19 interfere with everything?
So no, certainly I think you want to know that the CD19 is still present, and that's why before doing it again, I would want to do a biopsy. But if you do have further lines of experimental CAR T cells available that have different MOAs, then of course that's absolutely the right thing to do. And we certainly recognize that there are in many states where they've got extensive CAR T cell trials available, for example in China or in the US, then we're seeing that patients are being exposed to multiple CAR Ts, either with different co-stimulatory or different targets such as CD22, for example.
Thank you, sir.
Thank you, ma'am. Dr. Akanksha, your question, please.
Yeah, thank you, Professor Andrews, for the wonderful talk. So I have two questions. One is regarding the role of polatuzumab or any other maintenance therapy post autologous stem cell transplant for relapsed refractory DLBCL. And the second one is that since we know that polatuzumab doesn't prevent CNS relapses, so suppose you have a patient who has got a systemic and a CNS relapse of the DLBCL. So what treatment strategy should we follow in such patients?
Great questions, thank you. So I think there's no data to support the role of polatuzumab in the maintenance setting. We know that maintenance strategies in DLBCL have been really very disappointing so far. We haven't really seen any clear efficacy. For example, the lenalidomide study kind of just about failed its primary endpoint when given in elderly patients. Polatuzumab is toxic when given in cumulative doses. So when we first did the experiments with polatuzumab, we gave it until progression of disease. And there was a lot of toxicity, particularly neurological toxicity that accumulated. So there's no role for maintenance polatuzumab. The second question is about prevention of disease in the central nervous system. And this is a massive problem that we have time and time again. And again, you're right, that polatuzumab doesn't appear to prevent disease recurrence in the central nervous system. How do we approach that when patients either have synchronous CNS disease in the CNS and systemic disease? Well, our approach for them is to offer CNS penetrating disease that targets both the disease in the CNS and also the systemic disease. And we tend to use a lot of the Marietta regimen, which I'm sure you heard of, pioneered by the International Extranodal Lymphoma Group. And that's to use matrix chemotherapy, which is methotrexate and cytarabine, with some thiatepa, and ICE chemotherapy. And you can either alternate those, or you can give 3 of the matrix first and 3 of the R-ICE. And then we go on to consolidate the response with a thiatepa and carmustine-based autograft. And I think many patients do very well from this, and particularly those patients who have later relapses particularly seem to do particularly well with this regimen. So we take what we call the Marietta approach of induction chemotherapy followed by carmustine autograft.
Thank you. Thank you so much.
Thank you, Dr. Akansha. Sir, from the same note, in a patient who has got isolated serious relapse in case of DLBCL, the best approach, what you said, was to go for matrix protocol.
Yeah, so that's absolutely right.
Matrix and then 3 cycles of RIs.
No, so for patients, so that was for a synchronous CNS and systemic relapse. For a patient who has an isolated CNS relapse, then we would use 3 cycles of matrix regimen and then consolidate them with a CNS penetrating autograft. So again, a carmustine and thiatipa autograft. So treat them much like a primary DLBCL, primary CNS DLBCL.
So in case of isolated CNS relapse, in CR, after 3 cycles of matrix, what would be better? Thiatipa-based conditioning or to go for direct CAR T-cell therapy?
No, so I think we've got a lot to learn about CAR T-cell therapy in patients with CNS lymphoma, and we've got a lot to learn and understand about the potential neurotoxicity of that, and I think we've got a lot to learn about the efficacy of it. So I would offer this patient who was in a CR after having had matrix, I would offer them an autograft with carmustine and thiatipa.
And what would be the dose of thiatipa?
Oh, I can't remember off the top of my head. Sorry, I don't want to miscite a dose, but I can certainly follow that up if you want to.
Thank you, sir. Dr. Ashok Mishra, your question, please.
Sir, thank you very much, sir, for excellent lecture on DLBCL. So my question is regarding polatuzumab. So in Polaris trial, the subgroup analysis of Polarix suggests that Pola-R-CHP offers a greater benefit with ABC type of a DLBCL than those with a GCD, and particularly where it may or may not offer any benefit. So my question is, should we use Pola in GCP subgroup of a DLBCL?
So I think that's a really good question. Okay, I think that's really important. So remember, the analysis that was presented from the Polarix study in the New England Journal paper was based upon transcriptional analysis rather than based upon immunohistochemistry. Now, I'm not sure in your center what type of information that you're getting about the cell of origin for a particular patient, but I assume that it would be immunohistochemistry rather than defined by a transcriptional profile. And of course, there's a miscall with those all the time. So, sometimes there's a very clear-cut GCB, they're CD10 positive, that's straightforward. But often, probably 15% of the time, immunohistochemistry doesn't concur with transcriptional profiling. So I think that's one problem there. The other thing to say is that the germinal center group, within the germinal center group, is about 20% of patients who have what we call the dark zone signature, or the double hit signature, or the molecular high-grade signature. Different groups have called them different names. Basically, this is a highly proliferative tumor that sort of resembles centroblasts in the dark zone of the germinal center. They're highly proliferative. They have a poor outcome, and they sort of all have a shared transcriptional profile that's seen in patients with double hit lymphoma. Now, those patients appear to do really well from the addition of polatuzumab, but those patients who don't have that phenotype and are GC appear to do less well. So I think that actually omitting polatuzumab for GC patients is a reasonable thing to do, I think, because of the doubts. There is no doubt in my mind, I think if you've got a patient who is a non-GC, then I would really want to give them Pola R-CHP, but I think the evidence for the GCs is certainly less compelling than it would be otherwise.
Thank you very much, Professor.
Thank you, Dr. Ashok Mishra. Dr. Satish Kumar, your question, please.
Thank you, Amit. Thank you, sir, for that wonderful presentation. I had a couple of questions. One is in the similar case which Dr. Amit discussed, either primary CNS lymphoma or relapsed isolated CNS lymphoma. When you give matrix, when do you collect the stem cells? After 2 cycles, after 3 cycles, when do you collect the stem cells?
I generally try and do it after 2. So I do give them 1 cycle, It depends upon how their performance status goes. Sometimes these are difficult cases, aren't they? Because they might be neurologically significantly impaired. But generally, I try and do an MR after I've done about 1.5 cycles, just to make sure we're heading in the right direction, and then try and collect after 2, because you don't want to miss the boat with the stem cell collection. But you, more often than not, you don't have any compromise on collection after 3.
Right, sir. What is the CNS prophylaxis at your center for high CNS IPI?
Right. Good question. Okay. So I'm going to point you to a new position paper that has been published by the group in the British Journal of Haematology just this month. Okay. And it takes quite a pragmatic view on our approach to CNS prophylaxis. And I think it's a bit less dogmatic than other statements that have been made previously. I think that we have seen some large data sets that have suggested that the benefit of intravenous methotrexate is perhaps less strong than we had thought it had been. But I think we're all very conscious about the quality of that data. So the number of patients in any particular risk group, the number of patients that have any anatomical risk group, the changes in response criteria, the changes in diagnosis, etc., make us look on that data in a way where we have to exercise caution. But it's very clear that methotrexate, the benefits are probably quite marginal, if there are benefits, and I think it's important that we do not do harm. So that said, my approach is to assess patients who have got high risk disease carefully at the beginning, to look for occult CNS disease. So for patients with a CNS IPI of 4, 5, 6, I would like them to have a baseline MRI scan and a CSF examination. And whilst I'm in the CSF examining that, I'll give them some intrathecal methotrexate, 1 dose only. There's no reason to give patients intrathecal chemotherapy except for if they have testicular lymphoma. Okay. And for patients who I consider to be at high risk, so CNS IPI 5 and 6, or anatomical proximity to the CNS, or they have sites that we worry about CNS risk, such as breast, adrenal, renal, testicular, at the end of induction therapy, because their biggest risk is going to be from systemic failure rather than CNS failure, is that I make sure that they're in complete remission, and then I would offer them 2 cycles of methotrexate, 3.5 grams per meter squared, spaced by 2 weeks. Okay. And I think what's really important is that you select patients for that approach carefully. So for those patients who've got renal impairment, third spacing, diabetic or hypertensive kidneys, where you think that the methotrexate clearance is going to be compromised, then for those patients I wouldn't certainly offer it. But you don't need to give any more than 3.5 grams per meter squared. You don't need to give any more than 2 cycles. And I think if you do it that way and you do it safely, then I think that you can have an impact upon this, because I think the rate of grade 3 and grade 4 toxicity in these selected groups of patients is very low. I think that the marginal benefit is important, because what we do recognize is if you do get secondary CNS lymphoma, then the effects of that are devastating with a very high mortality. So for the moment, I want to say I recognize that we should be doing better for CNS risk, shouldn't we, than we are currently achieving with methotrexate. But I don't feel comfortable to completely abandon this in my patients yet, based upon data series that have too many faults in them.
Right. Thank you so much. Thank you.
Thank you, Dr. Satish Kumar. Dr. Roshni ma'am, do you have another question? Dr. Roshni Pandey ma'am? Well, yeah, okay. So we have some questions from the audience. So, and first question is from Dr. Krishnaratan Kannan. You mentioned that not all patients relapsing within 12 months will need CAR T cell therapy. Can you please clarify this?
Well, I think what I'm trying to say is that there are some areas where we're not entirely sure whether they do. So one of those was those patients who achieve a CR from their bridging therapy. There's one group of patients. We recognise that when I showed you that retrospective data from Spain, that there are a group of patients who achieved a CR who do really well with autograft, and also some of that retrospective data that demonstrated excellent outcomes if you achieve a CR and you get to the point of having an autograft. The question in the studies was not testing the power of the autograft. The study was testing against CAR T cells. It was testing the reinduction therapy followed by the autograft. So if you did a direct comparison of patients in CR after induction therapy between CAR T cell patients and patients receiving the autograft, we don't quite know which one is going to win. Now, if you're working in a resource-rich community where your patients are able to access CAR T cell therapy, then that's great. But I think what you shouldn't do is, if you are struggling to access CAR T cell treatment and you've got a patient in CR, you shouldn't feel that you're doing the wrong thing by offering those patients an autograft. So it's a kind of a pragmatic approach to things.
Thank you, sir. Another question from Dr. Krishnanathan Kannan. How do you decide for a patient who is elderly and has relapsed after 12 months? Do you still offer CAR T for such patients or go for high-dose chemotherapy?
Great question. The difficulty for me in the territory I work in is I'm not allowed to offer CAR T cells in the second line setting to anybody who is 1 day over 12 months post relapse. Okay. In fact, that our central health service counts the numbers of days from the last day of chemotherapy to when you want to give the patient relapses. So I can't use them for patients who have later relapses. Now, your health sort of economy may be a little bit more flexible about that. And certainly I know that, there's no magic about 12 months, 13 months, 15 months. These patients are all also at high risk. So I can't do any variation beyond that. And also, all our patients have to be considered to have been eligible for the ZUMA-7 study. So we would have had to have considered those patients to be transplant fit. So I have to say to our commissioners who fund the bills that if this patient I didn't have CAR T cells available, I would consider them to be absolutely fit enough to have an autologous stem cell transplantation. But that the fitness for CAR T cells and the fitness for autologous stem cell transplantation are very different. And I think that you could consider CAR T cells in an older patient, and we know that the kind of Alicante study has demonstrated that very nicely, where you wouldn't consider the fitness for autologous stem cell transplantation. So again, I think so in my environment, if I've got an older patient with a late recurrence and I thought that they were fit for high-dose therapy, I would offer them high-dose therapy because that's the option I can only give that patient. And then sometimes what we do is we play a little bit of a trick here, and we say, well, I've got this patient, I don't think they're quite fit enough for a stem cell transplant, but they're probably going to be fit enough for CAR T. In the second line setting, I give them some chemotherapy where my expectation of failure is going to be high. It's like our GEMOX, and then they bring the CAR T cell in the third line setting. That's just the unique situation of the restrictions that we have on CAR T cell use, that they've got to have been they've got to mirror the pivotal patient populations in the studies.
Thank you, sir. Another question from Dr. Karan. How do you make a distinction between PR and primary refractory disease based on PET scan?
So, I mean, we use the Deauville criteria, and we use the Lugano modification, which includes the Deauville criteria, and we look to see new lesions and to look to see the SUV uptake of the new lesions. We look to see cytoreduction in size of lesions, and we basically follow the criteria. I'm very fortunate that our PET radiologists and our radiologists who look at CTs are very good at working together to provide us information about whether we consider we've got a responding lesion that still has PET avidity, or we've got new lesions or growing lesions.
Thank you, sir. Another question from Dr. Yimon Tent. Which factors to be considered for CAR T-cell therapy versus bispecific antibodies in relapsed refractory DLBCL?
Great question. Okay, so really important. I think I spent some time in the lecture just trying to highlight some of the challenges around CAR T-cell therapy, and hopefully the bispecific antibody can democratize access for patients, and it can be at a price point where it's much more accessible. The bispecifics, here we can start those immediately, and I like to use those for patients often where the disease kinetics are more rapid. But the way that we use CAR T cells is generally in the second line setting for fitter patients, so I use a bispecific afterwards. But if I've got an older patient, then I can use a bispecific in that situation. So it's about the patient, it's about the patient's choice, it's about the patient's geography. For some patients, for example, we have in my own practice, we have a lot of island communities. That's really challenging for CAR T-cell therapy, etc. So it's a very patient-specific approach, and as I said, I think that we have still quite a bit of work to do to work out which is the best way around to do things. At the moment, of course, the CAR T-cell data is much more mature than the bispecific antibody data, but that will come as time goes by. But I think that there's great advantages to the bispecs in terms of the fact that we can deliver these in community hospitals.
True, sir. And another question is management for responsive to chemotherapy, but how do you manage any patient who is responsive to chemotherapy who has got residual lymph node of 1 into 1 centimeter?
Yeah, so the residual lymph node that's PET avid is always a challenge. I always try and do a biopsy if that's at all possible to look for active refractory disease. I think that's the most important. However, if I have a patient who a biopsy is not going to be possible, then I would offer those, with one on site radiotherapy as consolidation, and my radiotherapy colleagues are very happy to do that. We would normally give them 30 gray.
And if the patient is eligible for radiotherapy at the residual site and the lymph node is gone, would you offer maintenance?
No. So don't offer maintenance. There's no data for maintenance therapy in diffuse large B-cell lymphoma, which is a great disappointment. We've tried all different drugs. We've tried, there's a little bit of rituximab data, but it's not very strong. But we've tried lenalidomide maintenance, we've tried enzastorin maintenance, we've tried chemotherapy maintenance, and none of this has worked. So it's all about the induction regimens here.
Thank you, sir. And another question from Dr. Sanjukta Rao. She has asked about primary CNS DLBCL. How do you monitor post-transplant primary CNS DLBCL in CR, post-excision and rituximab?
Yeah, good question. So I generally, in the first year after completion of therapy, having achieved a CR, I offer these patients a surveillance MRI scan on a 3-monthly basis for the first year. And that's based on some French data, which demonstrated there would be an overall survival advantage from early detection of recurrence. I think, we have tools that might become increasingly useful. I've said to you about my doubts around CAR T-cell therapy, but it is an option, and you really want to pick these people up before they get deconditioned. And you know how difficult it is with some of these patients once they start getting a lot of neurological type symptoms. So I would just do that. Would be my approach. But I do think you need to have a goal in mind and a plan. And so there's any point doing that if you think you know what you might want to do at the time of recurrence.
Thank you, sir. And another question is from Dr. Sanjukta Rao, a patient of primary CNS lymphoma offered allogeneic stem cell transplant and has been relapsed after decreasing the immunosuppressive therapy to 50%. So how do you manage this patient now?
So, I'm not sure that there's good evidence to suggest that there's a graft versus lymphoma effect in primary central nervous system lymphoma. And that's something that we don't offer patients allotransplantation with CNS lymphoma because we just don't see those kind of responses, and that's been from experience. I'm afraid I probably don't have a clear answer as a result because it's just not within the scope of practice that I would do. You've tried, obviously, reduction of immunosuppression, and of course, if you could wean that off and get to the point of DLI, that would be worth a try. But I fear that if they've got progression, probably the right thing is whole brain radiotherapy if they've not already had it.
Absolutely, sir. Another question from Dr. Priyanka. Is CAR-T therapy or BITE cell therapy bridge to autologous or allogeneic stem cell transplant?
Yeah, so I think in terms of a bridge to allo transplant, yes, definitely, and we've talked about that in one of the previous questions. In terms of auto transplant, I think not, because the key thing about auto transplantation is that you are looking for chemosensitivity, and that's the clear question, because there's nothing special about auto transplantation. All it is giving more chemotherapy and then coming in and rescuing you from some of the toxicity. So what I want to know is, if I give this patient chemotherapy, are they going to benefit from it? And so we know that by testing with the induction chemotherapy regimens and then choosing patients for an auto based upon their response to the chemotherapy, if we use a bispecific, we just don't know whether that patient actually has chemosensitivity. So I think it's not unreasonable to think about that, and we'll probably get some data in the future. But at the moment, to my mind, I always reserve the auto for patients where I've demonstrated chemosensitivity. But for a patient who's had previous lines of therapy, including an auto, and then gets to a bispecific, then I certainly would think an allo. It doesn't matter how you get to the remission with an allograft, the effect is completely different how the allograft works.
Absolutely. Another question from Dr. Leong. Do you use rituximab in relapsed DLBCL where the repeat biopsy did not show CD20 positivity?
Yeah, good question. So generally, yes. Okay. We use generic rituximab. It's not very cost intense, and it is safe. And the reason we use it in patients where we've done a biopsy and it shows CD20 negativity is because we've absolutely recognized that there's heterogeneity in expression. So we may find sites of the tumor that are CD20 negative, and then if we look at an anatomically different site, we may see areas of residual CD20 positivity, and that it's we see different evolution of the tumor in different places. So for that very reason, and because of sometimes the quality of the stain may not be very good either, we always re-expose patients to rituximab at the time of relapse, because we think it's a low cost, low toxic intervention.
Thank you, sir. Another last question from Dr. Leong. What is your opinion on the prospect of this novel drug known as golcadomide, a novel cyclone E3 ligase modulator, that is CELMoD, in treatment of relapsed refractory DLBCL?
Nice question. So golcadomide, as you say, is a next generation CELMoD and has been developed by BMS, and it's been developed across a range of different B-cell malignancies, and we've seen some data to suggest that it's really quite effective in combination with, quite effective on its own, and we've now seen a little bit of data to suggest it's in combination with R-CHOP, it's quite effective. So it's now being examined in a first-line study against R-CHOP chemotherapy, so I guess we await the results of that. We've also seen some interesting data with golcadomide in follicular lymphoma as well. So I think I'm quite excited about it, but await more trial information.
Thank you, sir. So I've finished all the questions from the audience. Any discussants want to ask any other question? Well, so there are no more raising signs and no more questions from the audience. So thank you so much for that lovely and fantastic lecture. Wonderful learning we had today. Hats off to you. And I
Great.
all our doubts today, starting from many questions for repeat, but still it was, worth to clarify with you, sir. Thank you so much. thanks a lot for being our guest speaker today. And what a wonderful discussion. Thanks a lot.
Thank
sir.
you for having me, and enjoy the rest of your days. Thank you. It's been a great pleasure.
Bye-bye. Thank you, sir. Great day.